This is session number 7, pulmonary infections. Before starting this session, as part of the organizer committee, I want to thank Distribuna, our sponsors, and all of the great speakers that we have had today. And our next speaker had a personal issue, so he's not able to be here with us today. I invite you to ask questions so at the end we can speak among us. So, with no doubt, pulmonary infections are one of the main challenges that intensivists face. They can be acquired in the community, or we can have nosocomial infections acquired at the hospital, and this increases morbid mortality and hospital stay. I believe there are two elements that are key: early diagnosis and prevention. We have two experts today. We are here in Colombia and are going to speak about this. Dr. Francisco Molina, he's internist with a doctorate in clinical medicine and professor of Universidad Pontificia Bolivariana. He's going to speak about the molecular diagnosis of pneumonia acquired in the community. And the idea is to start treatment as soon as possible. This decreases mortality. And later, Dr. Marcos Gonzalez, he is also intensivist with a doctorate in clinical medicine. He is the dean of Universidad Pontificia Bolivariana and director of Hospital La Maria. And he's going to speak about his thesis, the prevention of pneumonia associated to ventilator. Now, Dr. Molina and Dr. Marcos, thank you so much for being here. Dr. Molina, go ahead. Dr. Guillermo, thank you so much for this invitation and your kind introduction. Now, we will start with this first talk. So my topic is molecular diagnosis. I don't have any disclosures for this talk. And we're going to speak briefly an introduction about the molecular panels. Second, I will review the evidence. And finally, the diagnosis towards the future. The way the panels have come up is because the cultures require a long time of incubation, almost 4 days. And the performance of a long sample through a lavage through fibrobronchoscopy is around 50%. And to classify the microorganisms as pathogen and commensal gives us a little bit a dichotomy vision, because pneumonia is an interaction between the host and the organism. And maybe a microorganism that is considered normal can have an important role in the pathogenia. And this cannot be included. When we speak about microbiota, we include all the microbes, fungus, bacteria, virus. And when we speak about microbiome, we are speaking about the genes and also the hostess genes. And this biosis is the alteration of the homeostasis of the lung, where we can have a decrease in the microbial diversity and an increase of some pathogens. That is why the concept of pneumonia is the interruption of homeostasis. So there is a lung dysbiosis. And to be able to do this kind of diagnosis, we need molecular tests. And we require the host response of cytokines. These are the guidelines published last year from the European Respiratory Society, Dr. Leches and Dr. Torres. In one of the question, it suggests when we send a sample could be benefited. And the consensus was yes. The benefit of these tests allow us to adjust the antibiotics in resistant pathogens that we not suspect. It has been demonstrated that the interval of waiting up to 3 days for a culture can start with an inadequate antibiotic in Pseudomonas aeruginosa and Acinetobacter baumannii. So we have to scale the antibiotics in 2 moments. First, when we have molecular tests, and a second moment when we have the results of the cultures. This slide showed the different panels that are available worldwide. The two most used is Univerocuretis from Germany and BioFire in France. And the one that is more popular, the second one, FEPIMCTI Pneumonia. And in less than 2 hours, we can have the result. Here we see the device, the sample is put through some ceramic beads, then the DNA is released and the RNA, the RNA in the virus goes to DNA, and we do a first PCR, where basically it allows us to go to another panel of bacteria, and according to the number of times that we can detect the microorganism, what we call the CT, this panel is able to detect, and it is expressed in copies by milliliter. This is a semi-quantitative analysis of common bacteria and atypical bacteria, 3 kinds, or 9 types of viruses, and 7 genes of microbial resistance. This is a good advantage of these panels. In carbapenemase and in beta-lactamase of broad spectrum for gram-negatives, and the gene MET-A for Staphylococcus aureus. The comparison of the different studies of these panels compared to cultures, here we see 259 patients in the US with pneumonia that had alveolar lavage. The FEPIMCTI detected also with the cultures 23% of microorganisms. However, the panels add plus 15% for bacteria and 29% for viruses. If we see these patients that had negative culture and that the panels were positive, half of them had received antibiotic previously. So this is one of the advantages that the panels have. And that is in patients that have received previously antibiotics. So it's a false negative of the culture, and this can be captured by the panels. These panels give a quantitative result. And if it's more than 10 to the 5, it corresponds to 10 to the 7 copies in the panel. In cases where the cultures are negative, there is heterogeneity of 10 to the 4 and 10 to the 5. The study determined early in less than 12 hours in 48% of the cases, adequate escalation or discontinuation of antibiotics. So this is an early phase of escalation. In the second study, done in New York, 298 patients comparing both techniques, it found that most of our patients had streptococcus pneumonia and Staphylococcus aureus. And the importance of this study to do the concordance of the culture and the film array, we see that the cultures are discordant in patients that had received previous antibiotics, and the positivity decreases, and mostly when the result of the culture is monomicrobial, not in the polymicrobial. If we have a mono, then it is detected more in a film array panel than in a standard culture. We also did a study of the concordance of the biofire film array, where we see here the co-infection of bacteria was detected in a larger percentage, in 24.5% with film array compared to 17% of the cultures. In both cases, Staphylococcus aureus in both methods was the most frequent microorganism. The usefulness of the panel is that for microorganism detected by the panel, a negative value is close to 100% of the cases where the cultures are also going to be negative. So if we have negativity in film array for those microorganisms, then we can be almost sure that it's going to be negative in the culture. Finally, this year, this is a study based on escalation therapy in Norway, 274 patients. They found that the capacity is increased when we direct the treatment with film array compared to culture, and the time is decreased once we start the definitive treatment. The second panel, Univero, in this slide, it also has genes of resistance. We have KPC, OXA, and cephalosporins, and other microorganisms like Pneumocystis tirovechi and Treponemonas maltophilae. And we also have studies where there is concordance close to 80% about the cultures. And it shows the usefulness in patients that are immunosuppressed and those that have received antibiotics previously. Comparing both kinds of panels, the film array pneumonia detects semi-quantitative. Univero is not quantitative. Univero has two microorganisms that the other one doesn't have, that we see on the slide, and the time is 4.5 hours, and BioFire is much faster, 1.5, the film array. Both have studies where they have early escalation of antibiotics and savings also because of the targeted use. About the new diagnostic techniques, in these panels, we do not know exactly if the microorganisms detected by DNA are alive or not alive. That is the future. I believe that many are working in this. And we have three diagnostic techniques. One of them is metataxonomic. We extract the DNA of the respiratory sample, and we do increased amplification of a gene, 16S for bacteria or the internal spatiator for fungi. The spectrum is not so broad, it's only for bacteria, and it doesn't say if they are alive or not. The report is not given in copies per milliliter, but in sequence amplicon variants. In the microorganisms and bacteria, there has been an 16S that is not altered throughout the years. Here we see fixed and non-fixed variants, and V3 and V4 are amplified by PCR. The second future technique is metagenomic. They sequence all of the DNA in the sample, bacteria, fungi, archaeas, and also the DNA of the human being. So it can tell us a metabolic pathway if it is functionally active or not. And finally, the great future is metatranscriptomic, to sequence the DNA, and then we will have the transcripts, and it will give us profiles of active microbiomes of high resolution, and it will do a research of the functional activity of the microbiome, and it gives us details of the functional elements, and it will allow to analyze the interactions between the microbiome and the host. And we can analyze the human and microbial transcriptions. We will analyze if there is dysbiosis. Everything is done through these sequenciation platforms like MySeq and HiSeq of short reading, and others. These are the short readings, and others are long readings with PacBio or mean ion of 4 hours. They are very fast, and it will give us transcriptomic information and have in the future a competition for the panels, because not only will we have this information early, but we will know if they're active or not. We have several studies, like in 2021, where in 100 patients, we increased the positivity of the recovery of the microorganism, 79 versus 39%. And these studies compare how can we decrease the rate of mortality and in the more complete resolution of the symptoms and decrease mechanic ventilation. This is a meta-analysis of 24 studies comparing metagenomics and the cultures. It says that there's decrease in mortality and also a decrease in hospital stay and in mechanic ventilation. About metatranscriptomic, this is a study. It's beautiful in COPD patients that had pneumonia. And how with metatranscriptomics and metagenomics combined, they can isolate the microorganisms. Here we see the 3 subgroups. One, where we have Streptococcus and Rotia, and subgroup 2 and 3. But in metatranscriptomics, we can detect which microorganisms are live, and they cannot be detected through panels or metagenomics. Metatranscriptome will help us even more, and it will detect the response of the host through the cytokines 168. And this is an interrelationship of the host and the microorganisms, and analyze the lung dysbiosis. Thank you so much. Thank you, Dr. Molina, for your talk. Dr. Marcos Gonzalez, he will speak after the prevention of pneumonia associated to the ventilator.
Thank you, Guillermo, for that introduction. A warm greeting to all those that are listening to us. A very special thank you to the organizing committee on the Critical Lung Day, on the eighth version, more successful every time. And I think it's an introduction on the evolution in pulmonary pathologies and critical care that are becoming very important for critical care and for surveillance of patients that are severely ill. I will try to give a very practical presentation from the point of view of preventing hospital-acquired pneumonia. As a main parameter, I have the pneumonia acquired in the ICU and more related to mechanical ventilation. Because this infection, this respiratory infection, is very important in critical care patients that have mechanical ventilation, and because it is the one that most literature has produced to study it because of the enormous public health problem that it presents. To tell you that I don't have any conflicts of interest, and I want to begin by Dr. Francisco Molina's talk that speaks about a genetic way of diagnosing the bacterial diagnosis in patients that have pulmonary infections. And these studies are coming in a timely manner. And they talk about DNA sequencing in patients that have a suspicion of this infection. And the advances in the metataxonomics, the metagenomics, and the metatranscriptomics. Because I think that that is the future of diagnosing pulmonary infections. And I say that because I like to begin there when we speak about how to prevent mechanical ventilation associated pneumonia. This article by Dr. Michael Compass from 2008, he is someone that is extremely interested in studying mechanical ventilator associated pneumonia, and especially a prevention strategy. In this excellent study, I believe, very educational, very descriptive, but very discouraging. And it is discouraging because in this study, we have a series of 25 patients in which there was an autopsy or a pulmonary autopsy, and they already had suspicion of pneumonia. They even had a course of antibiotics, a regimen of antibiotics, and they found that the correlation between clinical signs of pneumonia and what was found histopathologically, and this was very poor. So as you can observe on this slide, almost 30% of patients had a concordance between histopathology and what appears here. So it is very important to look at this discrepancy and to adhere to the diagnostic strategy that has the greatest sensitivity and the greatest specificity. So with the same study, there was a meta-analysis of 34 studies where there was a correlation of clinical parameters and radiologic parameters, also lab parameters, but not microbiological. And they found that basically the ratio of the probability was very low. When they spoke of a single diagnostic parameter, but as other diagnostic parameters were added up, the clinical signs of fever and increase of sputum, and if sputum had purulent characteristics, the probability ratio improved. But however, if we added to that high leukocytes above 1,000 or below 4,000, well, the probability ratio improved almost to 2. But when we added a new finding, for example, a chest X-ray that could suggest infection, then there was an increase in the probability. When the 3 possibilities were compared separately, the one that has the greatest probability ratio was a new infiltrate in the chest X-ray. So there's always the doubt that of what we're diagnosing in our ICUs is truly a pneumonia or not. So we see that 50% of diagnosis could be false positives and 31% false negatives. So without a doubt, transcriptonics is very important to improve diagnosis. They're also speaking of different biomarkers that can also improve that diagnostic possibility in patients that are in an ICU. And based on all of those difficulties for a clear diagnosis, the CDC in 2013 improved the diagnosis of ventilator-associated pneumonia in order to try to differentiate that not every problem that needs an increase of oxygenation or PEEP was a pneumonia. Basically, we could speak of a condition associated to mechanical ventilation. And if that condition was combined with clinical signs of fever and increase of purulent secretion, then we could speak of a possible or probable mechanical ventilation associated pneumonia. What is the difference between possible and probable? That there's purulent sputum or a positive culture, and the probable is that they have both positive. And then that improves the sensitivity and the specificity. And in the case that I'm going to present, we wanted to do a study of a prevention mechanism in ventilation-associated pneumonia. We based ourselves in the histologic criteria, which is the filtration of neutrophils, detritus, and fibrin in the intraalveolar spaces and the alveoli as well. And this was basically taken from the study from the group of Getafe led by Dr. Esteban that was published in the Journal of Critical Care. And Ventilator-associated pneumonia is important if the diagnosis is true, and of course it is. First of all, because mechanical ventilation in patients in an ICU is very frequent. From two patients, one has mechanical ventilation because of their baseline pathology. And that treatment with antibiotics that is given to patients that have a suspicion of ventilation associated infection have an increase in resistance because of the pressure of antibiotics. And additionally, there will be an increase in the stay in the ICU and increase in days of mechanical ventilation. If we speak in figures, we could say that if we're speaking of incidence as new cases, 9 to 27% is the incidence around the world. In Colombia, in a publication from the National Health Institute, we had 28.4% in terms of incidence. In Antioquia, with patient safety and surveillance and associated to hospitalization, we found that it was 26.56%. When we speak of rates as exposure to the endotracheal tube and mechanical ventilation per every 1,000 days of mechanical ventilation, in the United States, it is 2.8 per 1,000 days. In Europe, much higher, 14.2. And in developing countries, 22 per every 1,000 days of mechanical ventilation. When we have a ventilation-associated pneumonia, we also have to think about mortality that can be ascribable between 10 to 30%. Additionally, it contributes to mortality between 50 and 70% of cases. And the costs are important. A case of pneumonia in the United States is between $10,000 and $14,000. And in Antioquia, in a study that was conducted, it is $14,000 against $8,000 if there's no pneumonia. So yes, we do have a serious problem when we are in the presence of ventilation-associated pneumonia. Pneumonia, so that it occurs, several circumstances have to occur, and that the patient has an impossibility of defending themselves and have a good inflammatory response to control that amount of burden of bacteria that are entering the lung, favored by the endotracheal tube. The endotracheal tube, in our opinion, is the first risk factor. Patient that has an endotracheal tube is increased 5 or 10 times in the possibility of developing mechanical ventilation associated pneumonia. And in this very didactic graph taken for infection disease published by an Italian group, it shows in a schematic what the endotracheal tube is truly doing when it anchors, when it's anchored in the trachea of the patient, and it's an interface between the ventilator and the lung. Basically, what we're introducing into the airway is a device that in the first place is avoiding that the patient can defend him or herself with coughing and the cilia, and with the pneumotampon, it is putting pressure on the tracheal epithelium that can produce edema and that can also produce a false sealing and can let an overflow of secretions accumulated, as we see in the schematic, on the upper part and on the lower part of that pneumotampon. And the pneumotampon, according to the biomaterial that we have, can generate certain channels because of the folding of the biomaterial and allow the entrance of those secretions that are accumulated on the upper part and towards the lung. And additionally, all of the devices in the organism help with the creation of biofilm that protects bacteria from the defenses of the organism and from the antibiotics that are supplied. So, looking at our topic, how can we prevent a ventilator associated pneumonia? And I bring this review from Dr. Complas that appeared in the seminar on respiration in critical care medicine in 2019, where he basically says when we are preventing a pneumonia in the ICU, we must assess these five variables. If we're preventing pneumonia or events associated to the ventilator, that can be a respiratory symptom, that can be an atelectasia, that can be a pulmonary edema, or that could also be a barotrauma. All of these things. Also, if what we're preventing or generating is a reduction in the number of days of mechanical ventilation, hospital days, or mortality. So starting by the fifth variable, which is the most important one, all studies on prevention except non-invasive mechanical ventilation, post-extubation, no other one is going to reduce mortality. And we need to know that selective decontamination, gastric decontamination, yes, that helps the reduction of pneumonia and it improves mortality. And in the group of patients where they have studied trauma, and almost all studies, all important studies, come from the Netherlands. In Getafe, the group from Andres Esteban also has the strategy increased. And his statistics on pneumonia are enviable. So we don't know why the strategy that is so valuable, that is effective, is not implemented at a massive level. It seems to be that it increases bacterial resistance, but it's just a hypothesis because it hasn't been able to be proven. It's important to know that the best thing to not have pneumonia are oxygenation strategies that are non-invasive, such as the high flow cannula and non-invasive mechanical ventilation. There are other strategies that have been studied but do not reduce pneumonia or mortality, but ICU days and mechanical ventilation days. Important that Dr. Klumpa starts to speak of the effect of the change in geometry and biomaterial of endotracheal tubes. And a very important, significant situation is the aspiration of the drain. It has, whether it's intermittent or continuous, it has shown a reduction in mechanical ventilation associated pneumonia. The recommendation of Dr. Klumpas and of the World Health Organization is that we have to educate the critical care community so that they implement instruction packages that include all of these interventions to reduce ventilation associated pneumonia, or at least the days of mechanical ventilation and the necessary days for hospitalization in an ICU. With all of these packages that say that it's reduced in up to 50%, but when we're speaking of individual strategies, we do not obtain those results. And basically, the different publications on that regard speak to us about education and patient care more than these individual interventions. I thought this study was very interesting. It's recent. It's from Chinese intensive care physicians that had a strategy to review meta-analysis. It's an umbrella mechanism to see if all of these meta-analyses that we're going to see, these are 31, and to see if they truly have good evidence to be able to prevent mechanical ventilation associated pneumonia. And basically, what the study tells us is that all of these interventions prevented somewhat, but the best thing to prevent it is micro aspiration or broncho aspiration. If the patient does not have microaspiration, we are avoiding ventilation associated pneumonia. And here we can observe it. I pointed it out with these arrows. We can show what is most important. The most important thing is to drain continuously or intermittently these secretions. These channels that are being assembled on the upper part of the pneumotampon are fundamental and have important evidence to reduce mechanical ventilation associated pneumonia. So what is the problem really? The problem is the endotracheal tube. This is the evolution. These are the first tubes that were used for inhaled anesthesia. The first one is Dr. Frederick Echeverry. That was at the beginning of the 20th century. And it was improved with a pneumotampon by Dr. Gedde. And this was already used, and there was no leak of air from the retrograde lung or from inhaled anesthesia in those times. From then onward, they have been working a lot on the pneumotampon. Some are spheric, some are cylinder shaped, and some are cone shaped. And in addition, the material, polyurethane, silicone, and other materials. Additional to those geometrical changes and biomaterials, as I mentioned, you installed a canal for aspiration for secretions, and there were other devices to control the pressure of the pneumotampon. And you could also have coverage of the endotracheal tube with antimicrobials. And I bring this study that is basically the one that confirms with this meta-analysis that the drain of the subglottic secretion does prevent mechanical ventilation associated pneumonia with adequate homogeneity. And when we do the Hensel test, we can see that there is important protection that is under 60% in those patients, in such a way that I believe there's no doubt that every patient that is going to be intubated more than 48 hours must have a channel to drain supraglottic secretions. And from then onward, any advance in endotracheal tubes has to include this channel. The other issue that we also mentioned is to control the pressure of the pneumotampon. This meta-analysis published in Critical Care in 2022 also shows us that when they analyzed all the studies, there was an MH under 51%, but that what it is showing us is that there is a large heterogeneity. Those that studied this meta-analysis and we, the readers, we saw that there was better sensitivity of the studies, removing those that had a high probability of bias. And they showed only 5 that, and the weight of pressure was not as important. It was under 1, it was 0.85. And that additionally, it was very heterogeneous. And that the confidence index was over 1. So these findings are not strong enough in this meta-analysis. The other thing in this very good study from Philippa, and basically what it does is to have patients that had more than 48 hours mechanical ventilation, and they divided them into 4 groups. So one with the pneumotampons that were cylindrical in shape in PVC, PVC and polyurethane. And another group with a cone-shaped tampon, and the other one with polyurethane that assessed colonization at 72 hours, and there were no differences between the groups. And pneumonia up until day 28, and there was no statistical significance in terms that it protected the patients from pneumonia. This is the other study, the NASCENT. These are with the silver ions for endotracheal tubes, and they compared 1,000 patients with against another almost 1,000 with a tube that did not have that silver ion coat. And that in the first 10 days, there was an important reduction of pneumonia, 36%. It went from 9.8 to 7.2% in incidence of pneumonia. But in days of mechanical ventilation and in days of hospitalization mortality, there were no differences. So perhaps it might be useful so that the pneumonia can be controlled the first few days, but after the 10th day, we don't know if it controls it or not. What did we propose? We proposed an improvement in the endotracheal tube. We made an endotracheal tube instead of a pneumotampon, a diaphragm, a silicone diaphragm, and it had a ring. The upper part had a ring that allowed preserving its memory and adhered to the wall of the trachea. We did it in different diameters according to our experimental model with porks, 20 to 30 kilos. And we created an ICU with a veterinarian anesthesiologist, and we monitored during 72 hours. We intubated and we did controls, microbiologic controls at 0 hours, 24 hours, 48, and 72. We euthanized at 72 hours, but before euthanizing, we did methylene blue tests to see if there was any filtration of methylene blue towards the interior of the trachea. And then there was a necropsy and biologic studies. We have these statistical analyses to look at the significance. And it was a study approved by the ethics committee of the veterinarian faculty of SES University. What did it find? In terms of safety, there was no problem. They were easy to intubate. And the volume, the tidal volume didn't have any variation, and the expert didn't have any variation either. There was no increase of pressures, the plateau pressure, the dry pressure, the compliance was reduced somewhat without much importance. And we think that there was no pneumonia or any events associated to mechanical ventilation because we never needed to increase the PEEP for more than 48 hours. And we didn't have the need to improve the PiO2 in these porcine models. So with those variables, we can say that these tubes were safe. In terms of the lesions that it produced, we saw that in the larynx and the trachea, there were inflammation with lymphocytes and monocytes, some bleed, and lesions of the epithelium. Lesions, in some cases, an ulcer, in another case, some necrosis, and atrophy of the epithelial cells, but no important things. And in terms of histopathological findings in the lung, we found there were fibrins, especially in the fourth pig exudate, bronchial and alveolar exudate, and inflammation. The crosses is the intensity. The greater intensity are for crosses that none of the pigs had it. Additionally, these were the cultures that mention that there's colonization in these porcine models, and that in pork number 4, there was a Streptococcus beta hemolytic, and the other microorganisms were not frequent pathogens in the etiology of ventilation-associated pneumonia in human. What do we say? Well, with those findings, we have an adequate seal of the trachea, that we didn't have any pork that had filtration of the methylene blue. We didn't have any pork that have escapes of retrograde escapes of air. In other words, we believe that it has the adequate seal with the trachea. The second thing is that the changes in the lesions of the trachea and that we found do not vary with the literature that we reviewed, that basically the reports are 50 to 90% of patients. So we can say that it's not either superior or inferior to the lesions found reported in the literature with patients in an ICU and have mechanical ventilation of more than 48 hours. We saw that the nanoparticles that we added to these tubes that were filled with nanoparticles did not prevent colonization. In all the findings, we had biofilm with bacteria. We're going to analyze what could have happened with these silver nanoparticles and why they were detached, because at 72 hours, we did not see them in the tubes. And histologically, we can say that comparing oxygenation, comparing microorganisms, and the lesions that we found histopathologically, perhaps in a single pork, we could have found pneumonia. Of course, that one of the limitations of the study is that it was 72 hours, and we wanted a study for a longer period of time, but the ethics committees in animals did not allow for that. So we have that limitation. What can we conclude? That the main risk factor for mechanical ventilation associated pneumonia is the endotracheal tube, that in order to prevent it, we have to avoid intubation or reduce invasive mechanical ventilation. The instruction packages are not effective. It is more effective to have education strategies to implement these packages, and the greater efforts have to be focused to improving the geometry of the endotracheal tube. Thank you very much. Thank you, Dr. Gonzalez, Dr. Molina. Excellent presentations. And I don't know if anybody in the audience has a question, if you could write them in the chat, but I have a question. I would start first by thanking the speakers, both the experience and your own generation of knowledge through these approximations to infections. I would start by the end with Dr. Gonzalez. One point in common that has been mentioned both in community-acquired pneumonia as in prevention associated to mechanical ventilation, it is dysbiosis. And you mentioned something, Dr. Gonzalez, on selective gastrointestinal decontamination when there is strong evidence, but fear with the generation of bacterial resistance. Two interventions that could come close to solving or at least foreseeing part of the problem could be one probiotics and the other one inhaled anesthetics. What do you think of these two interventions to prevent ventilator-associated pneumonia? If you have any experience, what is your position with regard to that topic? Well, with regard to probiotics, we find more publications that probiotics protect from dysbiosis in patients that have mechanical ventilation, and that it's probable that there's a balance between the host bacteria, the protective bacteria against the pathogenic ones. And I think that that is an important intervention, and Dr. Klompas has that in its instruction packages, saying that it reduces the possibility of mechanical ventilation associated pneumonia, but it doesn't have hard results in terms of reducing mortality. But I believe that it is a possibility and that we should implement it as well in intensive care units. As also speak about mouth rinses or mouthwashes. With the disparity we have in the results and with a study that increased mortality, we see it, and we should have mouth hygiene, but with water, not with antiseptic washes or with chlorhexidine. And the other thing in terms of sedatives, inhaled sedatives, we had a very good experience during the COVID pandemic. I think it's a very good option, but the studies that are being published, they don't mention it as an important player in the patient that we have in the ICU because this inhaled sedation has not become popular here in our environment. Probably in the future, we might have important results in that sense. Thank you, Dr. Gonzalez. And I have two questions for Dr. Molina. One is exploratory. I wanted to know your opinion. And another one is from your daily practice. We are coming together to a metabolic response that was called the microbiome, which is an interaction with the host and the bacteria or the microorganism. And the exploratory question is there, we speak more of the metabolomic theory and early metabolic tests. Is there any type of literature that you have found in your experience from your PhD between metabolic changes and biomarkers or molecular changes of infection? And the other more pragmatic one is in your medical practice, the introduction of these panels in community-acquired pneumonia, even when we do alveolar lavage, we have a diagnosis of under 20%. Have you found more multi-resistant germs that are community-acquired? Has the empiric approach changed with these molecular panels? Two questions. One is very exploratory, and the other one is more pragmatic, Dr. Molina. And I thank you for your participation. Thank you, Guillermo. The first question, well, pneumonia is not foreign to what they have tried to do currently with sepsis, to phenotypify it in two types of responses. One is the inflammatory response or the syndrome of macrophage activation that the Greek group has tried to mention. It's a ferritin value of more than 4,420, and that is where the metabolic part comes in. The metabolic pathway of ferritin, and to be able to detect the increase in production of ferritin at the level of the alveolar macrophage. And the second phenotype, that is the immunoparalysis, that is given basically by the count of HLA-DR and monocyte CD24 and 45 to have less than 5,000 copies per milliliter. And that basically is given by monocytes less than 300, I don't know, hemoleucogram. And from the point of view of the metabolic pathway, we can see the low production in blood samples of metabolic pathways of low production of monocytes. So through metabolomics, we can also detect if the patient is in activation of the macrophage or in a state of immunoparalysis. That advantage is what metabolomics gives us. With regards to the second question, I think that currently film array panels are useful in several scenarios, and I will show specific ones in patients that come in with community-acquired pneumonia that are under mechanical ventilation. One, patients that have received antibiotics because the cultures there can give us false negatives. Two, patients that have immunosuppression. In other words, patients under the definition of immunosuppression, patients with steroids or with rheumatoid diseases or malignancies, etc. Three are patients that on a checklist have risk factors of multi-drug resistances because the film array panel brings the resistant genes, carbapenemous masses, and patients with less. And finally, I would speak of those that are post-viral pneumonias. Why? Because in the community, we have seen that post-viral, especially in influenza and COVID, staph aureus, methicillin-resistant RSA, is captured through a pneumonia film array panel. So those indications are clear in the early use of the film array panel. Thank you, Dr. Molina. Dr. Marco, I have a question from the audience with regard to questions. One question says, Dr. Saul Antonio Villagrán Marquez, what is the type of probiotic that would be more recommended to prevent ventilator-associated pneumonia? And the second question is related to your opinion on the aspiration of secretions through the endotracheal tube in patients under mechanical ventilation, or do you consider that it could be a contaminant factor? It's like Dr. Diana Rivera. Well, with regard to what type of probiotics, I truly am not able to recommend any because I'm still not very convinced of their role in our daily practice. So I would believe that each institution or each group should have their own staff to define which instruction packages they will implement to avoid that dysbiosis and maintain a balance of the bacterial flora. So I'm not able to tell you which is best between one company or another company. I could not consider it right now. The other thing is that in terms of aspiration through the lumen of the tube that is not closed and that should not be routine. And I will explain myself better. The recommendation that I would give for secretions through the lumen of the tube in patients under mechanical ventilation should be first through closed mechanisms, and second, not routine, but depending on the need. With that, we reduce the possibility of facilitating the transfer of secretions that the endotracheal tube towards the lower respiratory airway. That is the caution that we have in our group in terms of aspiration of secretions through the lumen of the tube. Thank you, Dr. Gonzalez. No more questions. So I want to thank you all, Dr. Molina, Dr. Gonzalez. Thank you for your time. Excellent presentations. I thank the participants. I thank these Tribuna and naturally the sponsors. And we will see you during the 9th edition of the International Lung Day, Critical Lung Day. Thank you all very much. Thank you for the invitation. Thank you all.